Hello, everyone. My name is Sharon Byron. I am the marketing manager for TruCode, and I want to thank you all for joining today's webinar, Bridging the Gap Between Coding and Revenue Integrity. I'm pleased to introduce today's presenter, Nancy Herschel. Nancy is the Vice President of HIM Services at Streamline Health and is a CCS and AHIMA approved ICD10 trainer. She possesses over 30 years of experience in health information, clinical data, and healthcare revenue management. She develops, administers, and manages services that address best practices in clinical coding and revenue integrity. Known as an innovator and a leader, she's developed and implemented programs and services including hospital-based inpatient and outpatient revenue integrity consulting services, nationally recognized training programs, HCC risk-adjusted data mining, auditing, and training services, and many others. Nancy's a member of the American Health Information Management Association, the California Health Information Management Association, the Healthcare Compliance Association, and the Healthcare Financial Management Association. Before I hand it over to Nancy, I want to review a few housekeeping rules to ensure a successful webinar. First, all attendees are in listen-only mode, which means you'll need to use your control panel to communicate. You can find your control panel on the right-hand side of your screen. If you need to minimize it to see your screen better, you can collapse and expand it by clicking on the little red box with the arrow. If you want to ask a question, you can do that in the questions section, which is towards the bottom of the panel. So to ask a question, just click on the little plus button and it will open up a text box. You can type your question in the box. At the end of the webinar, we'll try to answer as many questions as we can, but if we do run out of time, we will pass along any outstanding questions to Nancy and we'll make sure we follow up with you by email with an answer. So please make sure you send us your questions. I also want to point out that there are handouts for today's presentation, and that can be accessed from the handout section of the control panel if you want to print those out for reference. And finally, and most importantly, we want to make sure you receive your CEU. So tomorrow morning, we'll be sending out an email to all attendees with a link to a brief webinar evaluation. Please complete this evaluation, and once you submit your response, you'll be able to download your CEU certificate. If you have any questions or problems, you can always send me an email. Just respond to the webinar email invitation, and I'll receive it. And with that, I will hand it over to Nancy. Thanks, everyone.
Hi, everyone. It's Nancy Herschel. Sharon, thank you so much for the introduction. It is a pleasure to meet you all virtually today. We are going to hopefully spend the next hour talking about coding and revenue integrity and figuring out if we have really defined what coding is, because I think we all think that we know what it is, and sometimes I'm not sure that I do either. So I've been in the field for a long time, had the pleasure of working with many of the staff at TruCode, and remain committed to what we all do for a living. So whether you are clinical data professionals, whether you are managers, HIM directors, revenue cycle folks, we're all here for the same reason, and that is to figure out if we can continue to bridge coding and revenue integrity together and better understand the challenges that we face. So what we're going to do today, as part of our session, is to review the uses and applications of clinical coded data and kind of figure out if we really think we know all the things that coded data is used for. And we're going to talk about risk adjustments. And we're going to look into how so much of our payment world in healthcare is based on risk and adjustments of those risks. We're also going to talk about payment models. We're going to review 4 case studies, and at the end, if you have questions, we would like to share them, have discussion, and hopefully this will be a fruitful day. Usually I enjoy eye contact, so this is going to be a little bit different for me because I really want to see your faces. But just know that I am hopefully connecting with you, and that we will make this as an exciting of an hour as we possibly can. One of the things that I asked a group when I presented this information was, what do we do for a living? And there's always different questions and answers about that. Is coding an art or a science? Are we looking at qualitative or quantitative data? And really the answer is we're just a combination of both. So how we're going to start off today's session is by looking at today's healthcare revenue world, and looking to see that clinical and administrative data excellence is used to ensure that the provider, meaning the physician, the clinic, the hospital, receives appropriate and compliant payment in the fee-for-service world, but also in value-based payment worlds. So we know that we have ICD10 CPT and HCPT coding. We have charge coding. And for some of you on this call, if you are involved in any way on the outpatient side or even an inpatient rev cycle, when we think of coding, most people think of HIM. Truly, coding can be revenue codes. It can be drug codes. There's so many different quote-unquote codes out there that we really need to include charge capture and charge coding as part of what we define as coding. Other things that impact today's payment models are more subjective things like patient satisfaction. How is that measured quantitatively? We have disease management and outcomes management. We know that we have PSIs and HACs. We also look at HEDIS and the STAR metric program. We look at total performance scores. And then the clinical process of care, patient experience, outcomes, and efficiencies. These are the 4 cornerstones of value-based payment. And then we also tie that into pay for performance. So providers out there are being paid on their performance, and it's a question of what their performance is and how do we measure it. So I guess coming down to all of this, if you look at all of these particular bullets, and then of course risk adjustment, other than the ICD-10, which is in and of itself and HCPT self-explanatory, everything else, every one of these bullets is dependent on many data elements, but for sure dependent on clinically coded data. And we're going to talk about different applications of that clinical coded data as we go through the presentation. So we've got some pay for performance initiatives out there. Hospital value-based purchasing program, where inpatient payment rates are based on patient safety, outcomes, satisfaction, and efficiency. So we've got a whole bunch of PSIs in here. We have outcomes measures. We have readmission rates. This is really taking a look at the entire picture of patient care. We know that the federal government and other payers are looking at hospital readmission programs, and if we have hospitals that have excessive 30-day readmission rates, that for certain diagnoses that they're going to be targeted and penalized. We know about HACs, hospital-acquired conditions, that there is penalty, direct penalty for those cases to those hospitals that have high hospital-acquired condition rates. And then we've got MIPS, the Merit-Based Incentive Payment System, which is really a physician fee schedule that is changed based on quality, outcomes, resource use, which means utilization, use of the EHR, which was meaningful use, and then clinical improvement activities, so how a patient fares over time. So the question that we're going to look at today as we talk about our data and coding and what it means today is, how does a provider, a physician, a clinician, a hospital, and a payer, how do we describe how sick our patients are? So you always hear the doctor or the hospital say, well, my patients are sicker than the hospital down the street, so my rate should be higher. You have health plans saying that as well when it comes to, let's say, HCCs from Medicare. It comes down to these 2 elements. We have documentation for sure, and that's a whole bunch of things, mostly clinical. But then we have data. But the data isn't just demographic. It isn't just charge data. It's coded data. How do we know how sick our patients are? The only way we really know is by what the physician documents and what we have assigned as codes to tell the story of how sick the patient is or was. So risk adjustment has been going on since 1983. And I remember, I have to tell you, I am old enough that I remember the day. In 1983, I was fortunate enough to be working in a hospital in New Jersey, which was the beta state for the DRG system. And it was very exciting to be sitting in front of a computer screen. I'm not even going to tell you how big it was because you'll know then. I mean, you know how old I am anyway. But in 1983, DRG started and basically was a diagnosis-based system that severitized risk adjustment for the hospital and the physician, but didn't affect the physician payment, to say that the patient was either sick or sicker. Now, in 2007, Medicare said, okay, it's been a long time. We really need to take a look at this diagram and say there are really three kinds of patients. You're kind of sick, you're a little bit sicker, and then you are sickest. And then what you got in 1990 was the APR DRG system, which was really a question of taking a look at getting even more granular and saying, well, you're sort of sick, kind of minor, moderate, major, and extreme. All of these systems, all of these code-based reimbursement systems, whether it's the commercial ACA HCCs, whether it's Medicare, whether it's MIPS, any of these, all of these acuity systems, all of these payment systems are based on coding, on clinical coding, diagnosis codes, and obviously in the DRG world on procedure codes. So where do we get the code? We know where we get the codes from. The question is what and how do the codes work in this large payment world that we see. So I'm sorry, we have more attendees. I'm going to say, okay, bear with me, I'm going to go attached. So let's take a look at the lexicon definition. It's from JCO of what risk adjustment means. So risk adjustment is the severity of illness measures that are used, such as age, to estimate the risk, measurable or predictable, that's the chance of loss, injury, or death to which a patient is subject before receiving some healthcare intervention. This adjustment allows comparison of performance and quality across organizations, practitioners, and communities. So Sharon, I don't know, I'm keeping on clicking on OK. I hope that the rest of the audience is not being bothered by the message that's coming across with the 501 maximum.
You know what, we're not seeing it, Nancy, but I think there's a little box at the bottom. When you get it pops up, you can just click don't show this again and it should stop.
Okay, thank you. I appreciate that. I'm just glad that nobody can see it, but I'm glad so many of you are here. Okay. All right, so what I think is important is that basically this statement, which is really an actuarial statement that health insurers have used over the past however many 40, 50 years to say what are the risks of a patient getting sick, what are the risks of a patient requiring hospitalization or medical care, okay, and how much is it going to cost to treat. So again, we have charge data, we have length of stay information, we have a whole bunch of different variables. But the bottom line comes down to how do we describe our patients? How do we tell the story of our patients? And it really comes down to the codes that we, as HIM professionals and as rev cycle professionals and as CDI professionals generate. So I'm going to talk a little bit about some of the payment models. In a full risk adjustment model, it's called full risk, we know it is capitation. And capitation means that the insurance company basically says, this is how sick we think your patients are. We're going to pay you a per member per month fee, and this is all you're going to get. And if your patient is sicker than that, then it's on you to be able to deal with your financial loss in this issue. If your patients are healthier, then you're going to make money because you're not going to be seeing the patients anyway. So this is the full HMO as the day began. And there are still many programs out there that use straight capitation plan. There's another kind of program called shared savings, and this is not as popular, although I would love it to be, where you have providers that are rewarded if they reduce the total health care spending on their patients below the expectation that's set by the insurance company, by the payer. So it means that if the physician or the hospital is spending less than expected, that the hospital or physician will actually share part of that savings. The payer spends less on patient treatment than it would have otherwise spent, and the physician and our hospital are rewarded. This now, what we call shared risk, is a very, very common payment plan where we have Medicare Advantage, where we have different forms of risk and capitation together, which basically say if the provider does well and doesn't spend more, that's good. If the provider actually spends more than the payer expected, then the provider has to cough up the balance and make it whole. So if a provider contracts with a payer and the targets are not achieved, the provider, whether it's the hospital or the doctor, has to pay a portion of those costs back. And you could have 50-50 sharing. The relationship exists between risk and reward. And I assume that most of you on this phone are saying, what the heck is Nancy talking about? What does this have to do with coding? What it has to do with coding, and why every day when we're in the trenches, analyzing, reviewing clinical data, making code assignments, managing the data, every code that is generated, every ICD10, CPT, HCPCS, and even CPT level 2 code, every code has impact in affecting the payment and the shared risk. Whether we think it's just a DRG system or not, it's not. So just kind of keep that in mind as we understand, and I don't know about all of you, and I wish I could see your faces, but I have said this before. I've been doing this, and this has been in my blood for almost 40 years. Every year it seems that the work we do and the work that we as coding and clinical data professionals are asked to do continues to be more complex, more complicated, and I have to say that this year, in 2017, it has really reached a new level. I will say to you that I expect that it will exceed that level next year. And we need to really understand that the use of coded data is only going to become greater. And we're not necessarily going to just rely on a capitated plan where nobody really cares about how sick anybody is. We're going to be really looking at all of these measures to help providers and health plans come to terms with how to pay for health care. And we know our healthcare system is broken. It needs to get fixed. And there's a question I wanted to ask as we move forward. But HCCs, and I think everybody for the most part now is familiar with what Medicare Risk Advantage is. An HCC is a payment program developed by Medicare for those Medicare Advantage patients. It's not based on CPT codes and the level of acuity in a physician encounter. It's based on the chronicity and the disease management of Medicare Advantage patients. So in the Medicare system, just like it is on the DRG side, the dollars that Medicare spends is not fixed. So if Medicare Advantage plans increase their risk scores, which means that they're asking the physicians and the coders to be more explicit and code to greater specificity, if the health plan gets more money, then it would hopefully assume that the providers, meaning the physician groups, somewhat IPAs, would also get more as well. What happens with Medicare, just like it does on the DRG side, is that it adjusts the RAT factors, the risk-adjusted factors, just like the relative weights. So when we see more HCCs in one category, you may see that adjusted factor that measures its payment value gets reduced. But what's important here is that this is a totally diagnosis code-based system that focuses on disease chronicity. Now we have the HHS risk-adjusted model, also known as ACA and or Obamacare. And this is basically the same premise that we're looking at ICD10 diagnosis codes. But how the system is set up financially is different. How the system works, and it doesn't work this way in Medicare, is that when you have plans that are in the health exchanges or any HHS HCC plan. If you have a plan that has lower risk scores, meaning their members are not as sick, those plans give whatever monies they can or they're obligated to those health plans that have higher risk members. So it protects against adverse selection, meaning that if you know your patient has 3 or 4 really, serious chronic conditions that require monitoring, it's the whole getting away from cherry picking. But I think what's most important here is the plans with lower risk transfer payment to the plans with higher risk. In all the course, and maybe I need to spend some time in Washington, I don't know, I don't think I want to, but I don't know. Has anyone really heard, or has anyone really talked about why we've seen increase in health premiums under the ACA model? And I'm not telling you as a presenter that I know this is fact. It's a hypothetical question that I ask myself on a regular basis. If we have data, and this is for non-Medicare, younger population, and we don't tell the story of how sick these patients are, then these health plans are not necessarily telling the story, and their risk scores are lower. This really has a lot to do with diagnosis coding and physician documentation on non-Medicare patients. And there is a lot of work that I think we could be doing and should be spent on getting down into this. And I know that's a side note, but I just wanted to give you some insight into how important and what, if you were to ask a politician, and I guess I shouldn't say this, what an ICD10 code is, they might know. And then again, I don't know. So anyway, I wish I could see your faces, and I can't. But it is important to recognize that diagnosis coding in these models has a tremendous impact on the future of how healthcare is going to be managed. It's also important here that in the commercial or the HHS model, that these health plans have to spend 80% of each premium dollar on care and quality improvement. So it really is taking a look at outcomes. It's taking a look at CEO salaries. It is a very, very different model. So getting into some case studies and taking a look at how all this works. How are we understanding tomorrow's revenue? So the question that this Karen Lamb, a PhD, asked a few years ago, are physicians ready for the new value-based payment model? And the answer was, a year from now, you wish you had started today. So this is not just about hospitals, it's about physicians. And it's understanding that as we move forward, hospital and physician payment is going to become more and more connected, as it should be, or as it should have been. But whether we're looking at risk adjustment, whether it's in terms of MS or APR DRGs, whether it's PSIs or HACs, or value-based or MIPS or any kind of HCCs, the outcomes of care and practice patterns will still be based upon the data that's submitted, and those are codes, ICD10 CPT codes. So remember, coding, what we do for a living, what we manage for a living, are both qualitative, they say about the how, and then they're quantitative, they say about the what. So I thought at this point that we would have some case studies. Wanted to give you some examples. This is as much some critical thinking for us as clinical coding professionals and data managers to kind of think about the short-term impact of the work that we do and potentially some of the long-term impacts of what we do, and how do we deal with these situations. So this first case study deals with pay for performance, and the issue at hand is a catheter-associated UTI. So in December 10th, on December 10th in 2015, CMA made the following HAC reduction program information publicly available for each eligible hospital. And one of those measures was the CA-UTI, catheter-associated UTI, and SSI measure scores. So an SSI measure score was created by the National Healthcare Safety Network, called the standardized infection ratio, which is called CIRT, not to be confused with CIRS, just CIRS. What this does, it compares the number of infections in a facility to the number of infections that were predicted or would be expected to have occurred based on previous years' worth of reported data. So you're looking at a baseline to say 3 years worth of data shows that there were X number of cases in the state of Pennsylvania or the state of California that had catheter-associated UTIs. What can we expect in 2018, knowing what we've learned about treating these patients and outcomes measurement? So what this CEUs measurement says is if you have a score that's higher than a 1, if the hospital has more than 1, it's not doing too well, and the physician is not dealing too well, because these are also measured and tied to the provider ID. If your CEUs score is 1, that's average, is expected, and if you're less than 1, then you're doing better than average. So here's the scenario. This is an inpatient admission. We've all seen this before. It's a male quadriplegic patient that's admitted with clinical signs and indicators of a urinary tract infection. The physician changed the indwelling urinary catheter, cultured the catheter tip, and no bacterial organisms were identified. The physician documents in the final diagnosis UTI and quadriplegia. So the coder takes a look at this. CDI has looked at it, and okay, the patient had an indwelling urinary catheter, but the culture tip came back negative. So whether we're going to query it out, we're probably not. So we're going to leave this just as a regular UTI. So you know that you're in DRG 689, and this is your relative weight, and that's fine. Now, I'm looking at this clinically, and I'm putting these codes through my critical engine in my head and in your head and saying, what is the likelihood that a quadriplegic patient and a UTI that is just a UTI? It could be a 50-50 shot. But if the patient had an indwelling catheter, and it certainly would have helped if we had another secondary diagnosis code that said indwelling catheter, status, but we didn't have that. We go back from a CDI perspective, from a coding perspective, and we talk to the physician. We get more information, and we say, we learn, you know what, even though the catheter tip had no bacterial organisms, this was related to the fact that this is an indwelling catheter, and we need to make sure that we're doing a better job of managing whether it's office visits, whether it's ongoing in and out antibiotics. So the physician said, you know what, this really is a catheter-associated UTI. So we changed the PDX to this T code, which is a CA-UTI. We changed our DRG, and we're at a higher relative weight. So is everybody happy? So on the superficial value, yes, we've had a DRG increase, as we should be. And I'm in no way, shape, or form suggesting that we change or mold our coding practice or our queries or anything to get, quote unquote, the DRG that we want. But I am asking us to make sure that we understand that when we change this, if we get this P83 code, that this is going to affect our CEUs score, our infection score, and that we're going to need to take a look from a quality measure perspective as a provider and say, how many of these T8351s did Dr. Jones have? Is there a trend in pattern? Do we need to drill down into this data? Yes, you're being paid more upfront, but how can we do a better job knowing what the coded data really is to improve healthcare so that our provider is not ticked or dinged at the end of the day? We don't want to see a whole lot of catheter-associated UTIs in one respect, and in another we do because they, quote-unquote, initially pay more. So that's just one example of a case study of how our data is being used initially and then subsequently. And I do look forward to questions. I'm just going to go through the 4 case studies, and then we definitely should have enough time. So this case study number 2 involves a HEDIS measure. It involves chronic disease management, and is regarding HCCs, the STAR rating program, and even DRGs. It's about diabetes and osteomyelitis. So we're going to take a look at this scenario, and then we're going to get into some things that I don't know how many of you on the call are professional physician coding professionals, whether you are managing any prophy data. But even if you're not, it's very interesting, I think, to take a look at how deep our value-based payment systems are looking at all the data that we're generating in making global payment decisions. So this is an example of a Medicare Advantage patient who was seen by the physician in March of 2016. The physician documented type 2 diabetes on glipizide and metformin and had a hemoglobin A1C result of 8.5. The physician also noted chronic osteomyelitis of the left toe. Patient was treated with antibiotics on an outpatient basis, and the physician didn't document any relationship between the osteo and the diabetes. There were no changes to medication. Now, this same patient came back in December. The osteomyelitis had become acute. The HA1C results went up to 9.2. Fortunately, they were able to treat the osteomyelitis non-excisionally with aggressive antibiotics and wound care. And again, the physician did not document the relationship between these two conditions, the osteo and the diabetes. However, the physician changed the patient from these oral meds to insulin. So you're wondering, okay, Nancy, so what's the point of this example? The point of this example is that in the 5-star rating program, in the quality rating system, comprehensive diabetes care is one of those measures that physicians are being scored greatly on. Diabetes is one of the reasons that in the United States we have CM, a clinical modification. We have more diabetes patients than any other country in the world. And we need to get our arms around how do we do a better job of controlling it and of possibly preventing it. So the reason that this case from a coding perspective is interesting is these are two components in the CDC, comprehensive diabetes care. You've got your hemoglobin A1C testing, and then hemoglobin A1C control, which means that they're looking for most recent results of that blood test, of that monitoring level to be less than 8. So let's take a look at how the CDC, how the QRS takes a look at coming up with how they view this patient. Members are identified in several ways. The claim encounter data and pharmacy data. So the organization must use both methods to identify an eligible population. So you either have to have pharmacy RX data or you need to have a physician office or a hospital visit. If you're looking at the claim or encounter data, you have to have 2 outpatient visits to be considered a part of this universe of how the payer and how the world is going to look at how you're managing diabetes. So they want to see 2 outpatient visits. It could be in the physician office, hopefully not the ED, but it's here. And there has to be a diagnosis of diabetes in these 2 visits. The visit types don't need to be the same, but what's really fascinating here, if you're looking at how to analyze this, one of these encounters needs to be an acute inpatient encounter with some, doesn't have to be principal, but a diagnosis of diabetes. So in order for this system to be fully managing clinical diabetes, comprehensive diabetes care, you've got to be fairly sick and have other things going on, but certainly have a physician monitoring your care. Then in the pharmacy data, you have to be able to see that you're dispensed insulin or some kind of oral med. Okay, now here's a coding quiz. And I know you're not going to be able to answer my question. I want to tell you what the answers are. I want to ask you, and if you can answer at the end, these 3 codes are HCPCS Level 2 codes. We rarely see these on hospital inpatient claims data. These are not necessarily required data elements. If we're trying to manage and do a better job of preventing and halting the progression of diabetes, it would be helpful to assign these codes as needed. QRS looks at databases and looks for these codes to help in the equation. So I will tell you that this code, 3044F, is a HCPCS level 2 code that addresses the fact that your hemoglobin level, your most recent level, is 7 or less. This code, the 3045F, means that your most recent hemoglobin levels are between 7 and 9. And 3046F means that your most recent test results show you that the patient has greater than 9. Well, can you imagine if we actually collected this data every time we had an HA1C test done? The people who are looking at managing diabetes might be able to say, without even reading a chart, okay, this patient had a 9.2 hemoglobin. I think we need to do something with this patient before it gets to the point that they're in the hospital with acute osteomyelitis. So anyway, moving on to this story, this is how the numerator and the denominators are set. So you've got the ABC and the HbA1c test during the year. You've got whether or not the control number is less than 8. And if it's greater than 8, you've got a problem. Again, organizations that use CPT Category 2 codes to identify numerator compliance for this indicator must search all codes in the value set and use the most recent code during the measurement year. So that would say to me, every time we have a diabetic patient who's getting an H1C done, we should be collecting this level 2 code. So at a minimum, the medical record documentation has to clearly state why the patient was being seen, and also give the date that the HbA1c test was performed and what the results were. Needs to list the range and the result, and it needs to be identified whether it's an automated lab result or in a medical record review. You have to have this information available. So getting back to our world, so that's all the stuff that you're saying, Nancy, what the heck are you talking about? If you take a look at what we do for a living and what we're trying to manage for a living, in March of that year, this patient in the HCC world had diabetes without any manifestations and had a risk-adjusted factor of 118. Why was that the case? That was the case because in October of 2016, coding guidelines changed that we could include osteo as a with. But before that time, if the physician didn't make the relationship, it was considered separate. And on the physician side of the world, do we do physician queries on a regular basis? We probably should. But in the real day world of physician office visits, where we're trying to see 25 to 30 patients, if not that many, but whatever a day. Now, this same patient came back to the hospital, and the HCC data for that patient, you can see the difference. It went up to HCC 18, and you almost tripled the HCC value, okay, because you could make that relation. Now look what happened on the DRG side, okay? In March, if that patient was in the hospital, okay, they would have had osteo without diabetes, and you would have been in DRG 540, and you would have had this relative weight. In December, when the patient came in for non-surgical wound care management of diabetes and osteo, you ended up in a diabetes DRG with a lower relative weight. The point of this study, really, and this question, this case study is, as coding professionals, we come in at the end of everything. We're not involved in the mid or the front end piece. But if we were able to understand and collect all the pieces of data that could impact how this physician had managed this patient, would we have been able to say maybe the patient needed to be switched to insulin in March because he had more than an 8 HA1C. Now, you're going to say, Nancy, this isn't about coding. This isn't about what I do for a living. It isn't, but it kind of is, because the documentation that's present and the codes that are assigned that accompany them really do affect the outcomes of our health care payment systems and what's going to happen and how complex and rigorous our work continues to be. So I know that was kind of a convoluted case study, but I'm just asking you to think out of the box a little bit. So we've got 2 more case studies, and then we can have questions and all of that. But this is another important example, and I don't know, my brain kind of works, it's kind of odd, and for those of you on the call who know me, and I know a few people at TruCode do, I think when I'm coding as if I'm putting all of these codes kind of into an engine, and I'm trying to have deductive reasoning tell me if, then, what would be. So this case is a patient who was in the hospital, was admitted with CHF, and unfortunately fell out of bed and suffered a fracture of the right femur. The surgeon performed an open reduction, the CHF resolved. The pharmacy had charged for PO dilantin on a daily basis. And as a coder, as a coding professional, I saw that because in the system that I work in, I have access to daily charge data. So the H&P and the progress notes don't document any reason for the dilantin. Okay, well, I'm going to code CHF and the hip fracture. So I'm going to get DRG 983 because I have a major OR procedure that's non-related to the PDX. I don't have a major CC. The relative weight is this. It's healthy. It is what it is. But most importantly, this case failed PSI 08. This claim is subject to penalty because the patient had a fall, a hip fracture, not present on admission. So you're saying, Nancy, okay, what does that have to do with anything? So I'm going to say, as an inpatient coding professional, I don't know if I've studied every PSI exception. But if quality hasn't taken a look at this case before I've touched it, I'm going to be thinking about what do I need to know about in-hospital hip fractures, in-hospital falls, as I'm coding a case. So I go online and I find out what a PSI 08 really is. And it now targets all hip fractures from inpatient falls, not just those hip fractures that occurred post-operatively. So that means you're in the hospital for CHF, you fell out of bed and you fractured your hip. But what the PSI guidelines tell you is that there are exclusions. There are those secondary diagnoses that, if present, if documented, if treated, would take this case out of being a PSI issue. So, for example, if the patient had type 2 diabetes with a hypoglycemic coma, well, I guess so. If there was poisoning by unspecified antibiotic or poisoning by any med. If we had cannabis use with anxiety disorder. Or even if we had multiple myeloma. And the list of codes is enormous, the list of exclusions. So what the coder did in this case is say, okay, the patient's on dilantin. Nobody is really paying attention to this. And you know what? The CDI is looking at this even before the coder gets it. But if you don't have an active or robust CDI program, then it would fall on the coding professional. Why was the patient taking dilantin? The patient was taking dilantin because they had a seizure disorder, but the physician didn't mention it. If you get the physician to concur and say, yes, okay, I forgot, this is why they're on oral meds, if you add this G code, the G40909, seizure disorder is one of those diagnosis codes that is an exclusion, and it allows the case to pass PSI scrutiny. There would be no penalty. There would be no financial, quality, or any other risk to the organization or the physician. So again, you might not think it's not changing the DRG. Adding seizure disorder doesn't affect DRG payment. but it does affect the outcomes of whether or not you pass or fail a PSI initiative, which is significant in the overall reimbursement methodology that your providers in your hospitals and your physicians face on a yearly basis. So my very last case study example, again, it has to do with coding. It has to do with how we think about what we do. So again, not the same patient, but this patient is a Medicare patient admitted from a nursing home with CHF. And I'm underlying nursing home. And I don't know how many of you think about admission source when you're actually coding an inpatient chart, whether you have CAC available to you or not. Admission source is a really big deal. So the patient comes in with CHF. The patient received non-surgical wound care for treatment of a decubitus ulcer of the left heel. The CHF resolved. The patient was transferred back to the SNF. So we coded CHF, and we coded a pressure ulcer of the left heel stage 3. We're in an MCC DRG, and everything is fine. Now, do you think that that needs further looking at? Superficially, and I'm sure there were other chronic conditions, I didn't document them or use them in the example. But if you take a look at this from what is being presented, no, that's fine. Now, I'm going to say I'm going to put my PQRS hat on. I'm going to take a look at my hack hat, and I'm going to say this patient was admitted from a nursing home and had a stage 3 decubitus ulcer present on admission. I'm going to say, okay, Nancy, I really want to check to make sure that it was really stage 3, because if it was, that SNF has some issues. And that's an entirely different story. But then I go and I say, okay, and I look at the case, and I go into the coding clinic last year, and I see that there's some new advice that basically says, if you have evolution of stages of your decubitus ulcers, if you come into the hospital with a 2 and it evolves to a 3, unlike the rules in the past where you only assigned 1 level, 1 code, 1 stage, you now assign 2. So in this case, your level 2 code would be present on admission, yes, and your stage 3 ulcer would be no. So that takes this case, if you're looking this at from a pre-billing auditing perspective, or before you press the final key, or before any quality indicators are looked at by your CDI or quality staff, you're going to see that the DRG change drastically, because your pressure ulcer, stage 3, which is a major CC, is now an N. And because it's an N, it doesn't have major CC value. We're at a lower DRG. We've lost this much in payments. However, at the end of the day, this is accurate coding. This is compliant coding. And we also have alleviated, while we do have a hack issue, how come it went from a 2 to a 3, we also alleviated the risk of the OIG coming in and saying, we're going to take a look at all of your SNF admissions that have decubitus ulcers and see how you're doing in the staging. And trust me, and I won't say trust me, but I do believe that this will, if it already hasn't been, will be an issue that the OIG and the RAC are going to take a look at. So just kind of wanted to put the notions together, and I know we have a few minutes left, that what we do for a living makes us more valuable, and I use the word valuable in quotations because we live in a value-based world. So whether we're a professional coding analyst, whether we're a CDI, whether we're using tools or not, whether we're a physician, we really are ending up looking at the bigger picture and say, is the code not just correct, but is it accurate? Does it make sense? And if it is, then the payments associated with it will be meaningful. So one of the things that we are looking at, I'm just going to take a moment, in the work that we're doing, and we are a proud TruCode client, and I as an individual have been one for more years than I guess Becky can tell you all how many, but we are taking a look at some of the things that we just presented here to say, how do we take a look at retrospective auditing of random samples and move through a rules engine to be able to give you as a coding professional or a clinical data manager the ability to say, you know what, I need to stop and take a look at this case with a decubitus ulcer. I need to see, because it was a nursing home admit. How do we do that on an automated, pre-analytic, pre-bill basis? One of the things that we're working with at Streamline is this tool called Evaluator that actually does analyze all of the coded data and provide rules, narrative advice, and feedback so that we can learn and see data improvement as well as the outcomes of care being better. So I think it's just important that we spend a little bit of time thinking about what we do for a living and the tools that we use to help us do a better job. And one of those is certainly reporting. And for all of those of you, whether you code on a daily basis or whether you are managing the data, being able to trend and track and not use Excel is a really big deal. And I love Excel, but it is very, very interesting and more problematic. So on that end, Becky, Sharon, I'm going to say I hope you all enjoy this, and if there are questions, I'm more than happy to try to answer them. So I'm going to turn it back over to you.
Okay, Nancy, I do have some questions for you. This is Becky Degrosky at TruCode. Are you ready?
I'm going to try.
Okay. The first question is, if we do have a patient who is admitted with a catheter-associated UTI, will that affect the SIR?
The SIR most likely is based on if you're a Y or an N. Okay, so if you have a Y and you're admitted with it, it's not going to affect necessarily the hospital, but it is linked to the provider. It is linked to the physician. So if you have a catheter-associated UTI that's present on admission, that does link and go back to what the government is saying about how are we treating our patients globally. So from a hospital perspective, it shouldn't affect that SIR, but it does affect the provider. At least that's my understanding.
Okay, thank you. And I hope that answers the question of our attendee today. Here's another question for you. In your experience, where do all of the HCC and quality measure codes come from? Are they coming from the standard HIM department? And I'm interpreting this as, are the coders in the HIM department looking at the HCCs as part of their coding in your experience? And then secondarily, are they looking at the quality measures?
My experience is that for the most part, inpatient coding professionals are not seeing and do not have access to HCC data, and they are not exposed to or have access to all of these quality measures. Is that an issue? Well, if I'm the CFO or I'm the coding manager and we've got a DNFB that we have to contain and we've got AR issues, well, there are things that we may not be able to look at. In the broad scope of where I think we're going with advanced natural language processing and with advanced coding expertise, again, it's just my opinion to you as an audience, but I think we should be able to see this information and we should be able to understand it and access it. On the HCC side, the majority of diagnosis codes, and this is per patient per calendar year, most of the HCC quote-unquote diagnosis codes come from physician office visits. But every time an HCC patient, a Medicare Advantage patient, is admitted to the hospital, that inpatient data, those codes that you report on that patient, are also accumulated into the net bucket for those patients and how to calculate their yearly RAF scores. And it is clear that the richest source, and when I say rich, I mean quality-wise, certainly measuring acuity, but also physician documentation, the richest source of data is on the hospital inpatient coding side. So one of the things that health plans do is they spend time, and I don't know if any of the audience is experiencing this, where there's more of a focus, or somewhat more of a focus, not only on CDI for HCCs, but on coding auditing for HCCs, on diagnosis codes that might not affect a Medicare DRG or an APR DRG, but would affect a RAF score. So I think as we evolve and Medicare Advantage continues to grow, regardless of what the commercial side does, I think we're going to need to see more of this information. I hope that's helpful, Becky. But
I'm sure it answered the question. Thank you. Thank you. And then here's our final question for the day. Could or should we as coders ever take it upon ourselves to include the quality measure codes?
That's a great question. I think we need to know what our organizations are being asked to report, and I think that needs to come from higher up in administration. I don't think that we should necessarily be reporting those HCPCS or CP2 level 2 codes if we have no place to report them, or they're not going anywhere. But this is a discussion to say to your coding managers, to your HIM directors, to your rev cycle managers, okay, we're not collecting these, why or why not? So to answer your question, no, I wouldn't do it rogue, but I would present the issue of, well, why aren't we collecting them?
And that's a great answer, and I loved how you said rogue. It's the same way as any coding. You may really feel like you need to add or change a code, but we can't be rogues.
You got it.
Good point. All right, that's it. We have lots of folks telling us thank you for a great webinar, so I will also add to that. Thank you, Nancy, for a great webinar.
Thank you for having me, and I wish I could see all of you, but I just want to say thank you to each of you on this call for all the hard work that you do.
Thank you, Nancy. And would you mind, I think there's one more slide at the end that has some additional instructions, perhaps? Oh, nope. Okay.
No, it didn't. Okay. Sorry.
Nope, that's okay. So just as a reminder to everybody, there will be an email coming out tomorrow morning with a link to the recording of the webinar. It will also have a link to a brief evaluation form. Once you complete that evaluation form, you'll be able to download your CEU certificate. If you have any questions, you can contact me. But the link to the evaluation to access your CEU certificate is www.trucode.com/NovemberCEU. So that's the link you need, but this will also be in the email. But for anybody just viewing the webinar who didn't have the email, again, the URL is www.trucode.com/NovemberCEU. Thanks, everyone, and thanks, Nancy, and we'll see you on another webinar soon.
Thank you so much, everyone.
This is Becky. That information is on the handouts.
Excellent. Thank you.
All righty. Bye-bye.
Bye.
Bye-bye.